And so to start out, I want to talk about the concept of susceptibility, okay? Because as you know, not everyone, and in fact, most people, will not develop the disease of addiction within their lifetime. And in fact, what percentage roughly of the population will develop the disease of addiction in their lifetime? What's the incidence and prevalence of addiction? Does anyone know the number we use?
5%.
No, a little higher.
15.
Somewhere between 13 and 14% of people will develop the disease of addiction at some point in their lifetime, which by contrast means that 86, 87% of people are never going to get this disease, okay? Now, it's not a matter of exposure, because how many people, at least in America, will never be exposed to mood-altering substances? It's a rhetorical question. There's no answer. I don't know, but it's not many, right? The vast majority of people, Americans, will, on average, undergo 6 to 7 surgeries in their lifetime. All right. After most of those surgeries, you're going to get prescribed an opiate. You know, how many people never will drink any alcohol? Some, but not many. How many people never try marijuana, okay? It's not a matter of exposure. So the susceptibility is about other factors. So let's take a disease you're probably already more familiar with. How many of you have heard of diabetes? You guys all heard of diabetes? Okay. The most common type of diabetes by far is type 2 or adult onset, okay? So it doesn't develop until someone gets into their adult years, typically. It can develop earlier. What makes someone susceptible to type 2 diabetes? Who knows the answer? Sugar is incorrect, but good guess.
Family history.
Family history, very good. Genetics is what we're talking about here. You have to inherit the genes that make you susceptible to type 2 diabetes. All right? So you have to have the genes, the genetics, that make you susceptible. But that's not the only thing you need to develop the disease of type 2 diabetes. So that gives you genetic susceptibility, but that won't bring about the disease. What will bring about the disease for most people?
Diet.
That's correct. Sedentary lifestyle and excessive weight due to modern diets that are full of fats, and people become overweight. So you have susceptibility through genetics, and you have activation of that susceptibility through obesity or being overweight. All right. Now, if you look at modern diabetes statistics, type 2 diabetes, the old ones, I think it was about 7% of our population would develop diabetes type 2. Recently I read that it's a little higher. They're talking about maybe 10% of the population being developing type 2 diabetes. But only, that's a pretty small proportion of the population, considering that what is the current percentage of being overweight in American society for adults? How many adult Americans are overweight? And they have a definition for overweight. It's a BMI of greater than 27% of body mass index. What's the percentages for our society? Anybody know?
80%.
80? Yeah. Not quite. But you're closer than most people. Most people guess like 20%. 65% of American adults are overweight by the body mass index calculator. All right. So clearly, my point is clearly the vast majority of people who are overweight do not have diabetes, because only 9-10% of Americans have diabetes. So those people who are overweight and don't have it aren't susceptible. They don't have the genetic predisposition. Now, I'm going through all of this because now we're going to try and talk about addiction. Most people will not develop addiction in their lifetime, even though the majority of them are undoubtedly being exposed to mood-altering substances. So for those of you who have this disease, what made you susceptible? We already said it wasn't just exposure. Genetics is correct, partially. The genetics, undoubtedly, we know there are genes involved with susceptibility to addiction. Some of them we don't have a very good grasp on. The genetics for opiate addiction are quite complicated and don't fully make sense yet, although we undoubtedly there are genes that probably enhance someone's susceptibility to addiction to opiates. Alcohol, they've identified specific genes that increase the likelihood that you will be susceptible. Notice the difference in the terms I use there. Cocaine, they've identified a specific gene that increases the likelihood that you will be susceptible. When we're talking about addiction, we get into genes that are, for lack of a better lay term, potentially inherited in a dormant form. They're not active, they're not expressing. And if they're not expressing, they don't give you susceptibility. The difference is these genes can be made active. They can be turned on. There's a whole new concept called, it's not that new, called epigenetics, where through certain behaviors or environmental exposures, you can turn on a gene that was inactive in your previous generations that then gives you susceptibility or part of the susceptibility to addiction. We're not going to talk anymore about the genetics. It's actually quite complicated and we have a lot more to learn. But know that there are clearly genetics involved with susceptibility to addiction. And remember, I say susceptibility because you can inherit the worst genes in the world for addiction. And if you never get exposed to mood-altering substances, you're not going to develop the disease, right? All right, the other half of susceptibility to addiction is the psychological component. Now that's very different from diabetes, okay? And that's what we're going to talk about today. So to begin the discussion on the psychology of addiction, and by the way, SAMHSA, the Substance Abuse Mental Health Services Administration, and NIDA, the National Institute of Drug Abuse, the parts of our government that spend hundreds of millions of dollars to research these diseases, they currently put out a statement that says addiction, in their opinion at this point, is half due to genetics and half due to psychological factors in any given individual, okay? So if you have addiction, if you are one of the people here suffering from this disease, then this pertains to you, period. All right? So to talk about the psychology of addiction, we're going to go back in time and talk about the first person who ever wrote extensively about the subject of the psychology of addiction. And that was good old Dr. Sigmund Freud. Now, it is appropriate that he was the first person to write extensively about addiction because Dr. Freud suffered from addiction. He was a cocaine user for, I think it was around a decade. And he wrote an entire book, Coca Uber, in the late 1890s, about addiction and his theories and concepts about this disease. Dr. Freud was a big believer in obsessions and compulsions and how they would interfere with going through these childhood developmental stages, and how that, to him, that's what explained a lot of adult psychopathology. And his belief on addiction, the psychological component of it, was that addiction was a compulsion to seek pleasure. Which really just sounds like compulsive hedonia. It's all about just getting high. Now, unfortunately, that concept stuck around for a long time, many decades. And it wasn't until the second half of the 1900s that psychoanalysts who were researching the disease in thousands of other people, not just writing about their own experiences, started to realize there were some major fallacies in that concept. First of all, addiction tends to continue on long past the point where it's all about pleasure. And in fact, most of you don't get into here until the displeasure far outweighs the pleasure. And yet it still often takes external motivators to get you in here, even at that point. And second of all, if it's all just about pleasure, how come such a small, relatively speaking, percentage of the population suffers from the disease? Everybody likes pleasure. Okay. So a lot of people started to really research this disease. And they used validated psychometric tools, things where they could really measure people and their responses and the things that were going on in them to try and figure out this part of the disease. And they came up with what at first glance might sound similar, but is actually just the opposite of Freud's original postulation, which was it's a compulsion not to seek pleasure, but to seek relief from displeasure. Now, this makes addiction fall into a category of diseases of which we know there are quite a few, and that is diseases that are due to attempts at self-treatment. Okay? To understand this concept fully, we have to talk quite a bit about this illegible word here, displeasure, because they defined displeasure specifically, and they called it dysphoria. The first thing people want to do when they hear dysphoria is liken it to depression. It has nothing to do with depression. It's not even a distant cousin. It's not about inability to experience pleasure, which is a central component of depression. Okay? Dysphoria is most easily understood as a level of psychological discomfort. You know, physical discomfort we call pain. Psychological discomfort is what dysphoria is. But it's particular. It's psychological dysphoria, psychological discomfort in a social setting. You can't really be dysphoric if you're unfortunate enough to be stranded on a deserted island by yourself. There's no other people there. You won't be dysphoric. But when you're around other people, other human beings, you have an abnormally high level of psychological discomfort. That's the concept behind dysphoria. Many of you may have heard dysphoria described without the person using the word dysphoria. How many of you have been to a AA or NA or CA meeting? How many of you have been to meetings so far? Most people. Have you heard any leads at a meeting yet? Yeah. So when someone gives a lead, they're supposed to tell you how it was, what changed, and how it is now. And it's during the how it was that you'll hear people describe dysphoria. And the most common phrases that I've heard used are, I've always felt like I was different. Okay, when they say that, they're not saying I was different than the trees, right? I was different means I'm different than other people. I never felt like I fit in. I've never been comfortable in my own skin. I can never just focus on the moment. I'm always worried about what happened or what's going to happen. Okay. I've never been able to be myself around other people. That's what psychological discomfort refers to. In a setting, a social setting, a setting of other human beings. So the next question would be, how is that relevant to what would make someone susceptible to the disease of addiction? So to answer that, we're going to use a hypothetical graph here. And on the x-axis, we're going to have that dysphoria thing, the psychological discomfort around other people. So if you're down here at a 1, you're very uncomfortable around other people. And if you're up here at a 10, you're relatively quite comfortable around other people, psychologically speaking. Y-axis is just, given day, 0 to 24 hours. Now, in any given day, our level of comfort around other people kind of goes up and down. You do something embarrassed and you're a little uncomfortable and etc. But the difference is that the average level is very different for these two ends of the scale. So people with addiction would be considered to be down here on the bottom half of the scale. Okay? Doesn't mean you're extremely the worst, most uncomfortable around other people, but you're down here on the bottom half of the scale. And people not susceptible to addiction would be up here. So let's relate that to how that makes you susceptible. Well, if I give a mood-altering substance, a glass of wine, a Percocet, a line of cocaine, to a person who lives up here, and ask them what it does, people who drink wine with dinner and would never drink the whole bottle. Okay? You ask them, well, why do you drink a glass or two of wine with dinner? And they'll tell you, I like the taste. It enhances the flavors of my food. It relaxes me. Okay? Well, why wouldn't you drink 2, 3, 4, 5, 6, or the whole damn bottle? And they say, well, because then I would feel terrible. I would be sick and nauseated and clumsy and couldn't drive, and I'd wake up the next morning with a hangover, and there's no reason I would want to drink a whole bottle of wine. That doesn't even make sense. Okay? But ask someone who lives down here, what does a glass of wine or two do for you?
Makes you feel good.
Makes you feel good
Well,
or great?
great.
Great.
Good thing.
It also takes you away from whatever it was you were thinking about that was maybe bothering you.
All that psychological stuff that was making you so uncomfortable. Uh-huh. Actually, I can't tell you how many times when I've asked people their story of their first real exposure to a mood-altering substance, first time they, as a child or a teenager drank a couple of beers or used any other substance. And what they actually say is, it was the best I've ever felt in my life. Period. That's the best I ever felt in my life. How many of you here experienced that? Yeah. Okay. So it doesn't have this much effect. It has this much effect. It's taking you up to that level where you have no psychological discomfort. Mood-altering substances smother that stuff. They take it all away. The best I've ever felt. I've heard that quite a few times when interviewing people about this disease. Now let's look at the opposite. So obviously people who get a tremendous effect from a mood-altering substance are going to have a much, much greater motivation to repeat it quickly and more often. And as they develop tolerance, they're going to have more motivation to continue repeating it by increasing their dose, what we talked about in the last hour. But look what happens when it wears off. If you're living up in this area and you come back down to here, well, that's not so bad, right? But if you come back down to here, because this is where you live, and you just found out for the first time ever what it's like to be up here, the drive to repeat that behavior to get back up here to where you're comfortable is tremendous. Does that make sense? Can you recognize that effect in yourself if you have this disease? How many of you can recognize that that was what it was about? Mood-altering substances had a remarkable effect on you. Now, here's what I always get when I do this lecture on Tuesday nights and there's 100 people in here. I get the people who say, I'm not dysphoric. I'm not uncomfortable around other people at all. I'm the guy who's the life of the party. Just because you have, just because you have dysphoria does not mean you are aware of it. People have what are called defense mechanisms. You may have learned a long, long time ago to tell yourself that you're perfectly fine around other human beings. You're not uncomfortable at all. And those are the people who are often overcompensating. Those are the ones who sometimes get labeled as being egotistical, that kind of thing. Just because you have dysphoria doesn't mean you're actually aware of it. You may have developed defense mechanisms to not really recognize it. Okay? Questions about this concept?
I may have missed it, but what causes the dysphoria from the beginning?
That's an important. You didn't miss it. So his question is, what causes people to be dysphoric in the first place? That was what we're about to move on to.
Okay.
Very good timing.
The lecture you did before, you said like it's the most high we've ever felt. Was the lecture before like you're always chasing that what you had the first time?
Yeah, you can't get to the degree of euphoria you did the first time because your brain starts changing. Yeah. And people will talk about always trying to get back to it. Yeah, that can be part of it, right? But it's still that knowing that you don't have to be down here once you know what it's like to not be down here. What causes dysphoria? This is a great question. It's a central question, actually. And there's a difference for some people. Some people can tell you, I felt like I never fit in as far back as I have memories. And some people can tell you a particular point in their life in which it began. And some people used to be able to use mood-altering substances without abusing them at all or wanting to abuse them. And then something happened in their life and they became susceptible to addiction. In fact, something happened that made them dysphoric, psychologically uncomfortable around other human beings. Let me give you a couple classic examples of that. We already talked about the fact that in the general population, 13 to 14% of people will develop addiction within their lifetimes. If we look at certain populations, such as Vietnam veterans with post-traumatic stress disorder, we know that from studies that the incidence of addiction for them isn't 13 or 14%, it's 40%. That's more than 3 times the normal population risk. Well, it doesn't take a lot of thought to figure why a Vietnam veteran with post-traumatic stress disorder might be psychologically uncomfortable around other human beings. Okay, they were exposed to a horrific trauma in a war, and then they came back to America and the whole country hated them for being, murderers and child rapists and such. Pretty obvious why they're so uncomfortable in society around other people. The other example that I want to talk about for a second, because it's a big issue, is women who've experienced sexual trauma in their lives. There are some estimates that put it as high as 1 in 3 women will be sexually abused at some point in their life. And we do know that there's a subset of women in which the disease of addiction progresses extremely rapidly and becomes very severe. And that subset is women with a history of sexual abuse. So you can understand why they might be so uncomfortable in society around other people. However, what we really need to understand, and the importance of your question, is what is it? What are the problems in a person's psychological makeup that result in having this phenomenon of dysphoria? And why is this so important? Why do we need to know what makes someone dysphoric from a psychological standpoint? Well, because right now, those of you who are in here for treatment for the disease of addiction, you're assumed to have this. Remember, 50-50. You all have it if you have addiction. So you have dysphoria. So you're down here. You're on the bottom half of this scale. And you're literally down here right now because you are not supposed to be using mood-altering substances. In fact, we check you for that regularly, so I'm pretty sure none of you are. And if you're not using mood-altering substances and you have addiction, you're down here. Well, guess what that gets back to? That gets back to this concept of why the relapse rates for addiction are so high. Because when you become abstinent, you're back to being psychologically uncomfortable. And when you're psychologically uncomfortable, you're going to look for relief. If you got a headache and it goes on, you're eventually going to take something for the physical pain. You won't just ignore the headache forever. If you have psychological pain, and it goes on and on and on, you're eventually going to take something for your psychological pain. And there's only one thing that you guys at this point know of that treats your psychological pain. And that's a mood-altering substance. So we better figure out what to do with dysphoria, or your prognosis is not great. So, the psychoanalysts who came up with this new theory also took the effort and time to figure out the components of the basic human psyche that were damaged or defective if it's been since early childhood, okay, that result in dysphoria. And they came up with 4 basic components to the human psyche that seem to be not working correctly, if you will, damaged or defective, and that are the cause of someone being so psychologically uncomfortable. The first and the most important is the area of affect, and specifically what we're talking about are a person's mood or their emotions and feelings. Specifically, uncomfortable emotions or feelings that are relevant to another human being, which is the cause of most of your uncomfortable emotions and feelings, by the way, whether you realize it or not. Okay? They don't want to feel that. And so instead of dealing with the problem, you know, I think you have a problem with me, or I have a problem with you, so let's talk about it and figure it out. Instead of doing that, they don't even want to feel the uncomfortableness, the unpleasant emotion or feeling. And so they just want to suppress it, compartmentalize it, stuff it back there and not even acknowledge its existence. All right? That's an abnormal state. And that's what they do with most of those uncomfortable feelings and emotions. All right? But you can only do that so much until the compartment is full and it explodes. And then they're living in the second abnormal state of affect, which is way too much uncomfortable emotions and feelings all at once. Now, the second area of dysfunctioning is relationships. It's not that you can't have lots of relationships if you have the disease of addiction. The problem is, if you can't tolerate those uncomfortable feelings, particularly that have to do with other people, that means your relationships have to be maintained at a certain level of superficiality. You can't get past a certain level. There have to be some walls up, okay? You can't have the kind of psychological intimacy. We're not talking physical intimacy, but we're talking psychological intimacy that you need for your relationships to be nurturing. And human beings, to be mentally healthy, require very nurturing relationships. Interestingly, this gets back to a concept that was developed by Dr. Jung, Carl Jung, called the collective subconscious. His theory was that because human beings are such remarkably social creatures, that's why we have such a big frontal lobe, okay? We're highly dependent upon our social connections, the people in our culture, all right? We are also connected at a subconscious level. And if you're not connected at that subconscious level, then you will not be comfortable psychologically in that society. And therefore your relationships are going to not be as nurturing as they need to be, so they're too superficial. And if you can't deal with the uncomfortable emotions and feelings about interpersonal relationships, and therefore your relationships are too superficial, you're not getting the nurturing, you're not connected to the collective subconscious, then you will have problems. Good grief, let's try that again. You will have problems with self-esteem. You're not going to feel good about yourself as a human being if you're not connected socially at that subconscious level and even at a conscious level. That's just the way we are. That's the way human beings are. I don't care how much you want to deny it, and many of us do want to deny it. It's necessary for human beings. That's the way our brains were made. And if you have poor self-esteem because of this, then you're not going to be good about your self-nurturance, which basically just means taking care of yourself. It can be as simple as brush your teeth, wash your face, comb your hair, but it's much more than that. It's all the decisions that you make about your health and well-being, all your actions, decisions, everything you do in terms of taking good care of yourself. So these are the 4 areas of basic psychological functioning that seem to be deficient, defective, okay? that result in a person suffering with dysphoria, that results in seeking relief. And unfortunately, the relief from this displeasure ends up being the disease of addiction. The mood-altering substance become habitual. They change your brain. You lose control of your function, of your decision-making, and you have the disease of addiction. Does that make sense to everyone? Questions? Yes, sir.
Sorry. These are 4 components. You have to have all 4 to be dysphoric.
Yes.
But what is the root cause of having these 4 components? Is it something?
It could be traumas like we talked about with sexual abuse or PTSD from a war. It could be something much more complicated. It could be temperament. All children are born with different temperaments, and we know that temperament has a genetic component. And if you take 2 people who are exactly the same in every way except their temperament, theoretically, can't do this, okay? But you put them, 2 people, exactly the same in every way except they have different temperaments, and you give them the exact same exposures throughout life, they will be 2 very different people because of how they react to things. So could this be part of it? I don't know. That's theoretical. The problem is we don't know the answer to your question. What makes people have dysphoria if it's not a known trauma? You know, if it's not sexual abuse or you were in a horrible war, those kind of things. What causes people to be dysphoric? We don't know. It's an important question. Now, at this point, what we need to talk about is what can you do about this? Because if you're dysphoric the rest of your life, your chances of relapse are pretty darn high. You will seek relief at some point for most people. What about going to an individual psychotherapist? Would seem plausible, right? Go to a psychotherapist, someone who knows about these concepts, and work on these 4 areas of dysfunction. Actually, we don't think that works at all. And it gets back to this concept of the collective subconscious that Carl Jung, can't say that right, came up with. And that's that in order to work on these 4 areas of psychological functioning, you have to be in a true social setting. And a one-on-one therapeutic relationship with a therapist is not your actual real social setting. It's a fake setting. And you can't work on these areas of functioning with a therapist because it's outside of the boundary of the collective subconscious. So what is the one setting that you can think of where you might think that you could actually work on improving these 4 areas of function? Exactly. AA, NA, CA, Cocaine's Anonymous, those meetings are with your peers. They're with your real social connections. It's not a defined artificial therapeutic relationship. It's with people that you know and think are just like you. Now, just going to AA meetings won't work. And in fact, it's the 12-step participation that makes a difference. And let me show you why. What happens when you go to an AA meeting? Well, you can admit you have a disease, you can sit there and listen and participate and blah, blah, blah. But you're not really getting to any of those things. But what happens when you get a sponsor and start 12-step participation? And you have to get a sponsor. You can't do the 12 steps on your own, right? That's not allowed. It's not how it works. You have to get a sponsor to really start the 12 steps. And what's the first thing your sponsor should be telling you, and usually does? Call me. You guys heard that from your sponsor? Call me. A lot of them will tell you call them every day, whether you need to or not. And what's the other thing they say? Call me with every problem you have. If you got a problem, something's bothering you, if you have an uncomfortable emotion or feeling, call me and we'll talk about it. So now you've immediately started addressing number one with a real relationship, not an artificial out of bounds relationship, because it's part of your real social community. All right? And instead of being able to ignore all the things that bother you about your relationships with people, you start discussing them with someone. Immediately start talking about those. And most sponsors will tell you, don't make any major decisions about problematic things without calling me and talking about them first. All right? So immediately, you've addressed number two. You have at least one relationship that goes beyond those superficial boundaries. And you're talking about real problems, things that bother you, emotions you don't want to deal with. And as you stay involved in AA, NA, or CA, any of these peer community treatment groups, you start talking about the things that bother you with lots of the members of your meetings, the ones you get to know. Not just your sponsor. And as you start doing that, self-esteem starts to improve. And as self-esteem starts to improve, guess what? You're naturally going to make better decisions about your own health and well-being. As you feel better about yourself, you're going to choose the pathways that result in better outcomes for you. And while you're, in the meantime, until this gets better, you got someone else who you're sharing all the problems with to help you make better decisions. Now, how many of you have been to meetings and heard people talk about the common phrase, the one they use is, I lost the obsession to drink or drug? You guys heard that? People talking about it in leads? They don't have the obsession. They don't have the drive, the overwhelming desire to drink or drug anymore. And I think what that represents is that through being involved with their social community, through recollecting to the collective subconscious, the dysphoria is starting to go away. They're starting to move up this way on our graph. And if you don't have something that's causing you to be uncomfortable, you won't be seeking relief. The other example in which this becomes prominent is how many of you have heard of someone who was in AA or NA for decades, doing great, and some of them will tell you they went through this, and they stopped going. They stopped connecting with people. And you get one of two outcomes, almost always. The first and most common is they relapse. Could be doing AA for 20, 30 years, and they stop going, they think they're fine, and they relapse. And the second is that they absolutely refuse to relapse, but they're miserable because they're back to being dysphoric. And what do we call those people? Dry drunks. Heard that term? Dry drunks. They're miserable people. They're very dysphoric. They're no longer connected to the collective subconscious at all. And nobody wants to be around them, and they don't want to be around anyone. The point is, you can't cure these defects. You can get these areas functioning better. You can improve the functioning of these areas and lose your dysphoria and lose the obsession to use. But when you stop doing your maintenance therapy, the function of these four areas decreases, deteriorates again. That's why we say there's no cure for the disease of addiction. There is just the opportunity, the possibility of keeping it in remission for the rest of your life. That's why we tell you you need to participate in a 12-step program the rest of your life. That makes sense? Questions about that? Okay, I think that's enough for the morning. Thanks, everyone.